Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about hypertension and update. When I left off last week, I had already done two shows. I went over all the basics about things that cause hypertension, where it comes from, so on and so forth. In this segment, I'm going to just briefly go over the incidents. Around the world, 1.5 billion people suffer from hypertension. 1 out of every 4 adult men across the world suffer from hypertension. 1 out of every 5 women across the world suffer from hypertension. In this country, 1.3 million people suffer from hypertension. Very serious problem. So in this segment, I'm going to begin to show you how we evaluate somebody for hypertension. First of all, the blood pressure has two parts to it, the systolic part and the diastolic part. The upper part is the systolic part, the lower part is the diastolic part. They're both very important, but the systolic part increases the blood flow to the brain more so to perfuse the brain. The diastolic part increases the blood flow more so to the heart to perfuse the heart, even though both are super important. Now, the thing that has to be understood is that to diagnose hypertension, you really have to have the proper cuff, the blood pressure cuffs. That's the first step. If the patient has a small arm, you need a small cuff. The patient has a medium-sized arm, you need a medium-sized cuff. The patient has a large arm, you need a large cuff. If the patient is very obese and a big person, 350 pounds or over, you want a jumbo cuff. In my office, I have 4 separate cuffs as an internist. Why is that important? Well, if the cuff is too small, the arm is too large, the blood pressure is going to be falsely elevated by as high as 10 millimeters of mercury. If the blood pressure cuff is too large and the cuff is too small, the arm is too small, the cuff is too large, the blood pressure is going to be lower by as much as 10 millimeters of mercury. That's crucial. That makes all the difference in the world, okay? And of course, if somebody is markedly obese, 350 pounds, so you need a jumbo cuff, which I have in the office. If you don't do that, the blood pressure is going to be falsely elevated. And someone who has even if they have a large arm, you take it with a large cuff, but if it's really very big, you need that jumbo cuff. So that's the first thing you have to remember. In addition to that, when you're taking blood pressure, the blood pressure is taken in 3 separate positions. The patient may be sitting down, lying down, or standing up. In a hospital setting, the patient may be sitting on the bed or lying on the bed. It's crucial. The patient is too sick, clearly they can't sit down or they can't stand up. However, there are reasons why we may want to stand someone up to check the blood pressure, to see if the blood pressure drops after 5 minutes of standing up. That has clinical significance. So these are some of the points that you have to understand. In addition to that, the patient is an elderly person, a senior person. You must always take the blood pressure in both arms. You say, why so? Well, because of the possibility that the arteries in one arm may have occlusion in them. And if they do, that's going to lower the blood pressure. So if you take the artery, let's say in the left arm, it gives you one number. That number may be normal, 120/80, because there may be an occlusion there that you know nothing about, the patient knows nothing about. However, you switch over to the right arm, suddenly the blood pressure is 140/90. That's a big difference. In addition to that, you have to understand that blood pressures have been categorized from 1 through 5. From normal, which is 1, category 1, you have normal, then you have category 1, stage 2, stage 3, stage 4, stage 5. Okay? And these books that I've written, The Art and Practice of Modern Clinical Medicine, chapter 1 is on hypertension, very long chapter. This book that came out this year, African American Women's Health, chapter 1 is also on hypertension. Unfortunately, it may not be as easy as you think it is to get your hand on these books, but if you could, then you will be able to see how I completely detail all these things that I'm telling you about. So you evaluate the patient. After you take the history from the patient, total complete history, then of course you're going to take the blood pressure, take the pulse. Very important that the blood pressure is taken in an elderly person on both arms, as I just said, that the proper cuffs are used to take the blood pressure. And at the time that you're taking the blood pressure, you also have to check the pulse. Crucial. The quality of the pulse is very important. Is the pulse too slow? Is it too fast? Is it, you could barely feel it? Is it regular? Is it irregular? Or is it, you have a skip beat and when you're taking the pulse? Those are very crucial things to keep in mind while you're taking the patient pulse. You could make a lot of diagnoses. For instance, you could diagnose atrial fibrillation by just taking somebody's pulse. You could tell that somebody is having an arrhythmia of different types by taking the pulse, so on and so forth. Those are crucial things that you must know. Once you take the blood pressure properly, now you have to decide what to do about the blood pressure. But before you do so, however, now that the blood pressure is either normal, that's fine, that settled that issue. If the blood pressure is abnormal, then you really want to take a close look at the patient's eyes to see what's happening at the patient's eyes. Because you have to remember, when you dilate the eyes and you look inside with your little gadget, the eye is the only place in the human body that you could in fact see a naked vessel. Crucial. So high blood pressure can cause bleeding in the what we call end organs. We start with the brain, the eyes, the heart, and the kidney. Those are the end organs. What is the value of the blood pressure? Well, in order for you to remain active, symptomless, as it were, your pressure has to perfuse the brain, first of all. And if the brain is not being perfused, you feel dizzy. You could in fact black out. So the pressure is what allows the blood to be carried to a different part of the body, and the blood has oxygen in it. The oxygen is attached to the red blood cell, in particular the hemoglobin that is inside the red blood cell. That's where the oxygen is attached to be delivered throughout the different organs, from the toenail all the way to the earlobe. Because if that area, let's say your earlobe is not being perfused for a significant period of time, that tissue is going to die because it's not receiving oxygen. So the blood pressure is very important so that it carries blood, allow the blood to go to all the different organs in the body to be perfused with oxygen so those organs can stay alive. Problem is, however, when the blood pressure is high, that's a problem, major problem. As I stated last week, there are many reasons besides one inherits the gene that allow you to have high blood pressure. Every human being, doesn't matter the ethnicity of that individual, has in his or her kidney G protein coupled receptor kinase type 4. That's the gene that started out way in Africa many million years ago. That's the gene that I, from the top of my head, maybe some 30 years ago or so, NEDA, came up with and wrote it up, and this was by the people who are involved in doing research, tested it out. The researchers I mentioned in Georgetown University, University of Virginia, etc., discovered, yes, in fact, such a gene does exist, and it is located in every person's kidney. You say, well, how so? How did they determine that? Well, they did the research on Caucasian American, Japanese American, and Negroes from Ghana. They had access to 3 separate kidneys from these individuals. They grind them up individually and discovered the gene and the same quality, the same quantity in all these three kidneys. Hence, the reason for 97% of all blood pressures is the result of this G protein coupled receptor kinase type 4, which was subsequently published in the proceeding of the American Academy of Sciences in 2002. Okay? And subsequently, Yale University duplicated that research using, I think, mice or rat, found the same thing as well. So there is no if or but. And the powers to be in this country, there used to be a committee, I don't know if it still exists, that in 2007, the NGC7, whatever the name of it was, recommended that everybody who has functioning kidneys must first be treated with a thiazide water pill, which is the cheapest blood pressure medication available. That's not because it is cheap, they recommend it, because it is the right thing to do, because the basis for essential hypertension is salt retention. Salt retention. So therefore, you must prevent the reabsorption of this salt, which occurs in the tubules that prevent sodium reabsorption. Therefore, the sodium then comes out in the urine. Okay? And that is the basis for this treatment. So once you do that, then you are on the right path. And then if you don't do that, no matter how or why, how you treat the blood pressure, there are a lot of medications out there that I'll be talking to you about that can be used to treat blood pressure. If you give them in a normal amount or large amount, you could drop the blood pressure, but it will be transient. That's the point, because as soon as the kidney senses that the blood pressure is being dropped, and it is the job of aldosterone, which is the last step in the renin-angiotensin aldosterone pathway, is a salt retainer. Aldosterone level will go up, salt will be retained, water will be retained along with it, the intravascular system will be expanded, the pressure goes right back up. Because of all the many jobs that the kidney has to do for us to keep us healthy, okay, maintaining the blood pressure is one of the key jobs the kidney has to do. The kidney doesn't know that your pressure is high. All the kidneys know that you drop your blood pressure, the kidneys go right. And let me give you an example how crucial that is. I couldn't explain it to you better than that. Let's say for the sake of argument, you had a perfectly normal kidney function. Your BUN is normal, your creatinine is normal, and something happened. And that something could be a dozen different things. You suddenly collapse. You went into shock. Your doctor happened to have seen you last week and ordered a renal function. We know your BUN was normal. It was like around 15, 16. Your creatinine was 0.7 or something like that. We know that. And then suddenly, because of the shock, you lost your blood pressure. The kidney cannot be perfused because there's not enough pressure to perfuse it and help arrive, rush you to the emergency room. When you get to the emergency room, you're not urinating because there is not enough pressure to perfuse the kidney for you to urinate, but they're going to put the Foley in anyway. And the person in the emergency room that's taking care of you realizes suddenly, oh my goodness, your BUN is now 60, your creatinine is 0.5. Okay. Remember, it was 15 2 weeks ago, but they don't know that. By the time they get in touch with your doctor who had seen you a couple of weeks ago, he or she will tell them, oh yeah, that was the numbers then. So, but you didn't know that. All you know is that you receive a patient in the ER, the patient is hypotensive and shocked. You do the usual thing to try to save the patient's life. You send your chemistry to the lab, blood chemistry, and you have elevated BUN. You have prerenal azotemia. The question is, this kidney, here's the point. You want to find out, is this kidney has a chance of recovering, or since you don't know, was it a chronic kidney problem? Remember, I say you put the Foley in. Okay? You want to know? You don't need $1 million machine. All you need to do to answer that question, how you're going to manage the patient as well, is to take some of the urine that you get from the Foley, send it to the lab. Listen to this. Send it to the lab for urinary sodium. Okay? One sample. Not 24 hours, just sample urinary sodium. So far, so good, right? All right. So you get the result back. As soon as you get the result back, if you're a smart doctor, and believe me, a lot of smart doctors out there, the urinary sodium is going to be low. Let me repeat that. The urinary sodium of the patient whose kidney function was normal 2 weeks ago, who now something happened, he or she collapsed and shock, was brought to the emergency room. Now the smart doctor wants to know what to do, because you must know what to do. The kidney functions are now abnormal. You need to know there's certain thing you can or cannot do for this patient. Otherwise, you're going to make the situation worse. You need to know how to proceed. Okay? You're going to call your renal person. Believe me, they're very good, they're very smart. But guess what? Even before they get there, you, as an internist or as an emergency room doctor, will know that the urinary sodium is low. If it was a chronic kidney problem that caused the kidney function test to be abnormal, the urinary sodium will be high. Now it is low. That tells you right away that the kidney is holding on to salt, holding on to water to try to save this patient's life by trying to raise the blood pressure. Therefore, the urinary sodium is going to be low. That low urinary sodium, this is not a $10 million machine. That little test will tell you exactly how to proceed right there in the emergency room in terms of taking care of this patient. Okay? Because you need to know how much fluid can this patient get, how much she cannot get. You have to calculate the total fluid loss per day per patient, including the sweat. Then you know how to proceed, because you just heard from your colleagues who call in. Say, Val, I saw him or her 2 weeks ago. The urine was 15, the creatinine was 0.7. Right away, if Val is smart, and heaven knows Val is, you're going to know exactly how to proceed so that you help to save that patient, not only to save the patient's life, to save the patient's kidney, to allow that kidney to recover, because you know that kidney was normal last week, 2 weeks ago. And now that this is abnormal, there's a whole way, completely different way to proceed. How you treat that patient with IV fluid, how you calculate the loss from sweat, we do all this fancy calculation, and then you know exactly how to proceed. And sure enough, I guarantee you, if the patient survives, the blood pressure comes back up, within a week or so, that kidney is going to come back very nice and easy. The urine is going to go down. The patient is going to get better. The kidney is going to recover. Okay? It's crucial, because the way you manage the patient in the intensive care unit, the way you manage that kidney, that simple test that costs a couple of dollars, literally, to do a urinary sodium, and you could get it quickly. If you understand what it means, and I'm explaining to you what it means, that's how I'm giving you as an example, my friend, to understand the importance of salt. Salt is reabsorbed, the reabsorption of salt is blocked to the convoluted tubule. Okay? You block the reabsorption of salt by using the thiazide diuretic. That's how you prevent it. Different diuretics absorption is prevented in different part of the kidney. It is a elongated convoluted tubule. That's where you block the reabsorption of sodium. Therefore, sodium is going to come out. The water is going to come out with it. That's how you treat blood pressure with a diuretic, a thiazide diuretic. Okay? Completely different than we're using Lasix and Bumex. That's a different thing. That's a different part of the kidney. Okay, that's a loop of Henle. Believe me, I know that. That's a different thing. So therefore, then, if You add a thiazide diuretic, and the blood pressure is hasn't come down the way you want it to come down. You start with the blood pressure, let's say for the sake of argument, 150/92, just from the top of my head. Believe me, there's no rush. A thiazide diuretic can get started at that point. When you see the patient a week later, you tell them about their diet. But that diet is crucial, remember. In this country, the overall population consume 5 grams of salt per day. In the Negro slash African American community, they consume 5 grams of salt per day. The recommended by the CDC is 2.5 grams. 2.5 grams. Overall population consumes 5 grams. The black community consumes 5 grams. That's a lot of salt. And salt is the key. Now you understand, salt is the #1 cause of essential hypertension, salt retention. The gene that's located in the kidney was placed there by God the Powerful in Africa when the human race began, so as to allow those people to survive the horrible ambient situation that existed with temperature running 120, 125, sometimes 140, 50, with water being very far away, very scarce. So that's what God did. Who are we to question God? Nobody cares whether you think what you think of yourself. That's your business. You have every right to think whoever you want to think you are. But believe me, physiologically, medically speaking, as a physician, we must know how to treat you by knowing who you are. Because if we don't, we cannot treat you properly. And it is the job of a practicing physician to provide the best medication that can do the best job for the patient. If the patient refuses the medication, what can the doctor do? You have to go along, okay, the patient refused. If you disagree with the patient, discharge the patient from the practice, which I have done many times over the years. Because I have a responsibility to explain everything to the patient. In spite of the fact that I explain everything, he or she doesn't want the treatment that I'm giving, fine. That's his all right. I don't want to see you again. By the time, before you got home, that letter has already been typed. Believe me, that letter has already been typed. So the next couple of days, you can get your letter in the mail. I no longer want to take care of you. That's it. And I don't have to tell you why. I really don't have to. The law doesn't require that I tell you. I don't want to take care of you. That's my right. You have a right to choose your doctor. I also have the right not to take care of you if you don't want to go get treatment properly. Find another doctor. There are 850,000 practicing physicians in this country. Go and find yourself one. Okay? But if you want me to treat you, you're going to have to face the reality, because I cannot treat you properly if I don't know your physiology, if I don't know what kind of diet you eat, if I don't know your religious beliefs in terms that allows you to eat this or eat that. Your religious belief is yours, and I respect that, but that can create situation for me who's treating you based on what you eat, based on your religion. I need to know that. Not because your religion is not important. It is important. It's not kosher. But certain religion allows you to eat certain food, and certain food can cause certain diseases. How about that, okay? Because you have to understand, different ethnic groups are afflicted by different diseases more so than others. That is why the AMA and the other powers to be in this country have now realized, and they have realized in the last several years, 2, 3, 4 years now, that you cannot treat the patient properly, no matter what the people think, if you're not familiar with, sensitive to, and know the ethnicity, the different beliefs of the patient. You just cannot do it. You could do surgery on the patient, because 99.9% of the time you could find the organ the same way where they're located. Not general medicine, not general pediatric, not general OBGYN. You just simply cannot do it. I don't care what anybody tells you. It doesn't matter how smart you are. And believe me, this country have tons of smart doctors. But that doesn't necessarily mean they're doing the right thing all the time. This is not criticism. These are the facts. These are now the facts that we're dealing with. This is why the AMA have now given out grant to what, 33 schools the last time I checked that have taken the grant. Millions of dollars so that they can change the way they teach medical students, the way they teach interns and residents and fellows, so that they can become sensitive to people ethnicity and people physiology, because the different physiologies of different ethnic groups are different. So therefore, they get afflicted by different diseases. Women suffer more from certain diseases than men and vice versa. As a matter of fact, I predict when I'm dead and gone, there's going to be different medications made specifically to treat women and men. I predict that's going to happen. Mark my word. And this would be the right thing to do, because the physiologies are different. Because of the differences, we just cannot. Let me give you a classic example. I realize that I'm talking a lot. Let me give you a classic example. I have a lot of Caucasian patients in my office that suffer from heart failures. There's a medication, there's a combination medication out there called B-Deal. B-Deal was first found out on black folks to treat heart failure. It is a fantastic combination of medication. It has a water pill in it, has an alpha blocker in it, has a beta blocker in it, and it has an ARB in it. Fantastic medication. The best medication out there to treat heart failure and people who have a normal functioning kidney. Because you can't treat congestive heart failure properly if the kidney is not functioning well. Guess what? I have treated my white patients in my practice with congestive heart failure with B-Deal. They do just as well as the black folks who I'm treating for heart failure. Why shouldn't I? Okay? Because heart failure is heart failure. But in this particular setting, those are the best medication, because all the medications that are in B-Deal are good for white folks, and they're also good for black folks and other ethnic groups. Yes, that's why I'm able to do that. You must know who you're practicing, who you're giving the medication to, and why you're giving it is one reason, but who you're giving it to, because not all medications are good for all folks. All Caucasian folks can be treated with an ACE inhibitor. All non-Caucasian folk cannot be treated or must not be treated with an ACE inhibitor for heart failure. It won't work because they don't have enough renin. Their kidney don't produce enough renin for the ACE to block, to lower the pressure. So what are you giving to them for? So they can develop cough, because it's causing cough. It can cause you to sleep, and it can cause you to have edema in your leg. That's what you want to do, because that's what the drug companies want you to do. Give me a break. In any event, I'm stopping here. Next week, I'll continue to talk about hypertension. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.